everyone, and welcome back to Dr. Happy Vagina. And my name is Ida Bergman, and I'm a gynecologist working in Sweden, and I have started this YouTube channel to educate about women's health. And in today's episode we will speak about incontinence surgery, the TVT procedure. And TVT stands for tension-free vaginal tape. And in this video I will speak about what is a TVT procedure, which women can be helped by this procedure, which women should avoid a TVT procedure. I will speak a little bit about how the postoperative convalescence period, and also about the benefits and of course the risks with this procedure, because there is always risks with surgery. Even if they are uncommon, it's important as a patient to know about this before you say yes to surgery. And the TVT procedure is actually a Swedish intervention, so we are very thankful to Dr. Ulmsten, who invented this procedure in the 90s. Okay, so we will speak first about the indication to surgery. So this surgery is for women with stress urinary incontinence, and I have a different episode where I speak more thoroughly about what is stress urinary incontinence. But in summary, I will draw here the urethra and the urinary, the bladder. And the supporting system under the urethra, we have fascia and ligaments, we have a muscle around the urethra, and we have pelvic floor muscles around the urethra. And if these supportive structures become damaged, often the main risk factor for stress urinary incontinence is vaginal delivery. When you give birth to a baby, you might lose these supportive structures and you get a hypermobility in your urethra. So the support under the urethra gets lost. And when you put pressure on the bladder, for example, you cough, you sneeze, you go out jogging, or you do X jumps or other kind of physical movements, the pressure on the bladder stresses the urine to come out, and we don't have any support to block it. And when you do a TVT procedure, you will make an artificial support under the urethra. So when the intra-abdominal pressure makes the urinary bladder move, we also have a movement of the hypermobile urethra, and this TVT tape will give an artificial support that stops the urine from coming out involuntarily. And there are two main types of TVT bands, because it's a little blue plastic band. It's approximately 1 centimeter in thickness. We have the TVTR method, TVTR, the retropubic method, and we have the TVTO method, the obturator method. And it's the same kind of sling. The retropubic sling goes here up underneath the symphysis on the both sides, and it's like a hammock underneath the urethra. This is, here we have the pubic bone, so this is the retro, it goes behind the pubic bone, goes up like that. The other method is the obturator method that has another angle but gives the same support. It goes underneath the urethra here and comes out. This is called the obturator membrane in the pelvic floor, and the tape comes out from the obturator membrane like that and comes out in the groin. So if we look afterwards at the scars, we see that there is a little scar underneath the urethra. We put the band and it comes up, and if you have the retropubic band, you will have two small scars just in the lower part of your abdomen. And if you have the obturator band, you will have the scars on the inside of your groin. Okay, so these are the two main types, and we will speak a little bit more about these later on in this clip. Okay, and this surgery is done normally as a day surgical procedure. It means you come to the clinic in the morning fasting. The procedure takes just a few minutes, and usually the most clinics, at least in Sweden, don't give full anesthesia. They give some sedation that you get sleepy and groggy and usually don't remember so much from the procedure, and then we put a lot of local anesthesia. We do the procedure a few minutes, and after you come to the back to your bed, you get to eat something, and you will see that you can pee afterwards, because when we put a lot of local anesthesia, it's a little bit swollen in this area. It can be a little bit difficult to start voiding. So this is something that we want to control in the beginning. Some women have difficulties voiding the first day because of this swallowiness and because of all the local anesthesia, and you might have to go home with a urinary catheter that you can remove the day after. And usually the convalescence period after your procedure is not long. After a few days, you can usually go back to work and go back to your normal activities of your normal life. And usually the pain is not, for most of the women, the pain is not very severe. You can take paracetamol and ibuprofen for a few days. This is usually enough. Some women have more pain and require morphine tablets the first day, but this is uncommon. And the first days you can shower, but you should avoid taking a bath until all the scars have healed, so that no bacteria will enter into this surgical area. Okay, and what kind of success rate do we expect from this procedure? We have different studies showing a little bit of different figures, but if you're a normal weight woman under the age of 65, you can have up to a 90% cure rate that you will get rid of your incontinence symptoms. And other studies show up to 80%. We put a happy smile there. And we have long follow-up studies up to 30 years after this procedure, showing that for most of the women the effect is durable over time, because this plastic band, it grows into your pelvic floor and it stays there for the rest of your life. It's not resolving over time, it stays there. But if we look at women who are a little bit older, maybe older than 65, they have a little bit worse success figures, maybe 70%, 60-70%. And this is due to sometimes when you are older, it's not just only that you have this hyper mobility of the urethra that I was drawing before. It can also be that you have aging factors in your urethra that makes the urethra more rigid and a little bit more open, like a straw. So it's more a problem inside the urethra than outside of the urethra. And if you put a band here, it doesn't help with the inside problems of the urethra. This is why we cannot promise the same cure rates if we have a woman that comes with her symptoms in a more elderly age. Also, obesity is a risk factor for worse results. We see that women with a BMI, body mass index, over 30 has a success rate of only 50%. Also varies little in different studies, but a high BMI is a risk factor for treatment failure, but also for complications. So we really recommend weight loss for women with urinary incontinence, because this can reduce a lot of the symptoms. Sometimes you don't even have to undergo surgery if you can manage to lose weight, but also you have a better outcome and lower risk for complications if you can lower your weight before surgery. Okay, so this was a little bit about the statistics. And women also ask, is there a difference between these two methods? A long time we have said no, because the studies have shown that it's the same cure rates. We have a big Cochrane, a lot of studies showing the same results of retropubic and obturator method. But now with long-term data, we have some little studies indicating that there might be a little bit more durable results with the retropubic method, but it's not really confirmed that you should choose one over the other. So both are used, at least in Sweden. So now we will speak also a little bit about the risks with these procedures. We can divide it into short-term risks and long-term risks. So the short-term risk, it means something that can happen just after your procedure or under the actual procedure. And one risk factor is that you will have a UTI, that a bacteria will enter the urinary bladder because you are doing surgery in this area. This is a very uncomplicated complication. We can diagnose it, give you antibiotics, and you will get cured. So UTI is one risk factor. There are also a risk for more severe infections, so that bacteria will enter this space where the plastic band is, and you can have a surgical site infection, and these infections can be very severe, and so severe that we have to remove this band and give antibiotics for you to heal. So surgical site infection, it's very, very uncommon, but it exists. And a third risk factor is that the band can sometimes move and be a little bit too tight, and this makes the voiding problems not disappear. So maybe you remove your catheter after 1 or 2 days, you still cannot pee. This means that the band can be a little bit too tight, and we have to do a procedure to loosen it. If we see after 3 or 4 weeks that the band is too tight, usually it's not possible to remove this band because it has already attached so hard to the pelvic floor. And in this case, sometimes you have to cut the band to loosen the tightness. So voiding difficulties is one risk factor. So these are the main 3 short-term complications. And then also something that I want to mention is when you do this surgery, there are nerves, there are blood vessels, and there are bowels in this area. So there is a risk that the band, when you put it inside, that you will perforate or damage a nerve or a vessel or a bowel or the bladder. So organ injury is one risk, but it's very, very, very uncommon. Maybe 1 in 1,000 women will have this complication. We call it organ damage. So these are the short-term complications. But there are also what we call long-term complications that comes along after the procedure. And one complication is erosion of this band. So it means that the band starts to travel or move and starts to erode and eat itself into other organs. For example, into the urethra or into the bladder. So tape, we call this tape erosion. The tape can also, or the tape or the sling, we call it, we give it different names. It might start to travel and move outside, so it starts to expose itself in the vagina. We call this tape exposure. Tape exposure, and this might give symptoms that you will get excessive discharge or bloody discharge or pain during intercourse, or your partner might feel this scratching sensation of the tape. Also, you can have chronic pain in your pelvis, or dyspareunia. So pain only pain or pain during intercourse. We call that dyspareunia. And these long-term complications, they are very, very rare. The studies show maybe between 1 to 2%. 1 to 2% gets these complications, but for the women who are affected by these complications, it's a very big issue. And in Sweden, we have started centers for mesh erosions, where women who have these kind of complications can get really expert help. So we have especially trained doctors who are specialists in treating these kind of complications. Sometimes you have to remove parts of this mesh totally or partially. Okay, so I think now we have gone through all the most important aspects of the TVT and mesh surgery. And I want to just summarize that this is an amazing intervention that has given back the life to many, many women, because stress urinary incontinence is very common. It's super disturbing, affecting young women in the middle of their life. And this is the most effective procedure, but it comes with the risks, and you have to be aware of these risks when you sign up for surgery. And you have to feel that you have done all you can do with conservative treatment before you opt for surgery, and also that you have enough symptoms that really bother you so that you are willing to take all these risks. All right, I think that was all for today. See you next week when we will speak about another type of treatment for stress urinary incontinence. Bye bye.